critical care medicine, and I'm doing a fellowship in child abuse. So, and he's here. So my obligatory disclosure slide, I have nothing to disclose. So just for fun, I thought I should try to put some of child abuse, pediatrics, and protection in perspective. And you can tell I have elementary age children. So I thought, well, this would be a fun timeline to put together with some of the amendments that we're studying occasionally at home, with some important things that have happened in the prevention of child abuse and child protection throughout our country's history. Some of these things are obvious, like the Second Amendment, obviously a very low number, happened very early. And something that happened more recently is our first child abuse pediatric subboard was offered. Some other important things, I think, that have happened in our history, the 15th Amendment, is the right to vote. If people saw the movie Lincoln, that happened soon after that movie ended. The 19th Amendment, the right to vote for women. And some other things that happened very early in our nation's history, prevention of cruelty to children and to animals. These happened in New York a long time ago. Publication of the battered child syndrome. And so if you had to put these in order, I'll help you out a little bit. These are the obvious ones, right? And the Second Amendment has been important in the news recently with respect to protection of our children, or not. And then, what I'm trying to get at is sort of how things have happened with the protection that we provide children throughout history. If you had to put them in order, do you know how you'd put them in order? The 15th? Close. Yep, there it is. So the 19th Amendment didn't happen until 1920. So what I want to focus on is the late 1800s for a very brief story that puts these two things, the prevention of cruelty to children, and ties it to the prevention of cruelty to animals together in a not-so-obvious way. The publication of the battered child syndrome happened in 1962, and it wasn't until 2009 that the first subboard for child abuse happened. So what I took away from some of this, besides it was sort of interesting in thinking about this, was that it's a very slow evolution for child abuse pediatrics compared to most of the other subspecialties in pediatrics. So this is a story. This happened in 1873, so right before the Society for Prevention of Cruelty to Children happened in New York. This was about 2 years prior. So this is Mary Ellen. She was 10 years old in this photograph. She was orphaned when she was 2 years of age. She was taken in by a non-relative female. Mary Ellen's neglect and physical abuse were not secrets to the people that lived in the apartment. It was sort of obvious to them what was going on. Etta Wheeler was a woman who lived in the neighborhood, worked at a local church, and she heard of what was happening to this child, and she asked Henry Berg for help. Henry Berg is important because he was a lawyer. He happened to be a lawyer for the Society for Prevention of Cruelty to Animals. At least the story goes, it's more important that he was actually a lawyer. So Etta Wheeler didn't know what to do. She turned to him for help. They obtained documentation and witness reports from the people who lived in this apartment. They submitted them to a judge within 48 hours. They removed her from this home. They placed her in a shelter. She then spent time living with two other families until she was an adult. She actually lived till she was 92 years of age and had her own family and stayed in touch with Miss Wheeler until they both passed away. So an interesting history about child abuse and protection just in general. The objectives, I'm going to focus on fractures. That was in the title, but I'll touch a little bit on child abuse just in general. So why common abusive bone injuries in children are missed by well-intentioned medical care providers. I'll talk a little bit about why that happens, and it's pretty obvious once you go into some of these stories. I'll try to go through what's known about the mechanism of bone injuries, and then I want to review some data regarding fractures such that physical abuse is appropriately placed in the patient's differential diagnosis. So, speaking to a room full of pediatricians, everybody knows fractures are common. They're common pediatric injuries. They account for about 20 to 25% of childhood injuries. There's about 125 fractures for 100,000 children who are under the age of 3 years or less. About 25% of these occur in children less than 12 months of age. Some fractures are highly specific for abuse, but it's important to know that no fracture is diagnostic of abuse. So what I'll go back to over and over again in the talk is that it's the constellation of the patient, what you understand about the patient, the history, and the radiologic studies, which are really important and help differentiate between abusive and non-abusive fractures or other pathologic bone diseases. Because I have so much to talk about between just fractures of otherwise healthy children, I'm not even going to touch on pathologic bone disease. So here it is in another format. In order to provide the best medical care, we really have to understand our patient. The patient's age and development go into how we understand our patient. What we see on physical exam is important. What we know about the history of the patient and what brought them to medical attention is really important. Was the accident or something observed about the child that brought them to medical attention? And people talk about in the literature understanding kind of all of this together, not just what's possible with the patient and the injuries, but what's plausible, what actually makes sense. And then tying all these things together, we need to understand our radiologic studies, what they're telling us about the patient's health, and the type of injury that they've had. So somewhere you want to be in the middle here, taking all these things together. So overall physical abuse, this is just to impress on people that this is a problem. So the prevalence in 2004, these were confirmed victims of abuse in children, all types of abuse. So it was a little over 150,000. And those were the confirmed cases. Therefore, people estimate the number is obviously going to be much higher than that. And so it's really an important goal not to miss those cases that come to medical attention, and physical abuse of some type is not even entered into the differential diagnosis. We have to consider it. So why is physical abuse in general missed in the differential diagnosis? I'm going to talk a lot about Dr. Pierce. She is an emergency medicine physician at Northwestern, and I have a lot of her work in here. One of her papers, she kind of gets at this, about why people miss this diagnosis, why medical providers miss it. There can be preconceived bias. For example, the socioeconomic status of a family may allow or prevent physical abuse from entering the differential diagnosis. Fixation errors, there might be red flags or other data which are just ignored, or incorrect data is applied when trying to think through the patient. And knowledge errors. The lack of knowledge prevents appropriate working diagnosis, or in other words, if you never consider it, you'll never diagnose it. So again, notice I've mentioned differential diagnosis several times. So focusing more on abusive fractures, there is a recent study that looked at missed abusive fractures. So a large children's hospital in Toronto, they looked at, they had 258 children over 1 year, aged 3 years of age or less, who presented to their emergency department with fractures. They found that 20% of the abusive fractures were missed on their initial presentation. When they went back to try to figure out, well, how did they then make the diagnosis on those 20%, kids came back with subsequent trauma or symptoms. 16% of those presented back with additional trauma. There were subsequent red flags that were picked up by somebody, and then they called the family back and then made the correct diagnosis. Sometimes an incorrect radiologic reading was done by the primary care provider who was seeing the patient, and then subsequent to that, radiology read the x-rays, made the correct diagnosis, and then they got the family back. And occasionally, physical abuse was suspected in a sibling, and then somebody put it together, and it got them back to the initial patient that was in this study. So in this study, they found that 3 variables were associated with missing a diagnosis. One was where the patient presented. If the patient presented to a non-pediatric emergency department or a primary care setting, they were more likely to miss the diagnosis than if they presented to a pediatric emergency department. A male patient was more often missed, twice as often as female patients. The authors had no explanation other than people felt that, well, okay, maybe injuries just happen more often with male patients. And then if you had an extremity fracture, you were more likely to be missed. And they felt that that's because extremity fractures are very common accidental fractures. They're also common abusive fractures, and they have very low specificity for abuse. So their summary was that 1 in 5 abuse-related fractures were missed on initial medical presentation. They also felt that non-ambulatory children were at high risk and warranted a child abuse team consultation. They also felt that there should be a low threshold for using a skeletal survey so that you wouldn't miss patients, and consultation with radiology, and that a detailed review of the mechanism of injury and screening for other risk factors for abuse would be helpful. So the first 2 are very clear to me. I get that. This was not as clear to me. I didn't know what they meant, and they didn't refer to anything. So I tried to find some more information about, well, what are the risk factors? So I found another study. This group was from Sydney Children's Hospital, and they were trying to sort of get at the same question as well. And they made a list of 8 indicators that they said would increase suspicion of abusive fractures. So in my mind, that means you put it in your differential diagnosis. But this is their wording. So what they did is they took a fair amount of literature from the late 1990s with fractures in kids 3 years of age and less. They put it together and they said, okay, these are 8 indicators that should be red flags for that we need to look into this further. And they included an incompatible or inconsistent history, any child less than 1 year of age with a fracture, patients with long bone fractures and other injuries, prior presentation to the emergency department with a long bone fracture, some delay in presentation that wasn't well explained, unwitnessed injuries, patients that presented with more than 1 injury during the 1-year study, or patients that presented with more than 1 fracture during their 1-year study. So this was their criteria. They had 100 children that presented with 103 fractures. 31 of them had indicators that were suspicious for physical abuse. And here they are. These are the 31 children. 17 had 1 indicator, 11 had 2, and 3 had 3 indicators. Of these 31 children, only 1 was referred to their child abuse team. That 1 child was 18 months old. She had a fracture in her fibula with no mechanism of injury and delayed medical care. She was the only one that was referred. So their conclusion was that knowledge of common indicators that would put abusive fractures into the patient's differential diagnosis were infrequently used in their emergency department. Now, these haven't been validated. They're just trying to find a starting point.
Did they mention about how many kids had 3 indicators and were not abusive in nature?
No, right. So it's not validated. They just are picking things that are they think would be high risk, where we should at least, in their opinion, their child abuse team should have been notified, and they weren't.
But they didn't say anything about how sensitive or specific.
Correct. Correct. So other thoughts about why fractures are missed by healthcare professionals. Occult injuries and fractures can be missed with non-mobile infants because they're not going to demonstrate to you that they have a fracture as easily as a toddler who's walking around. And I'm going to go into more depth about that. And then also people in the literature talk about just this lack of making a connection between the mechanism of injury and the observed injury on radiologic studies. And I'm going to try to go into that a little bit more. So how did these fractures present in physical abuse? It largely depends upon the age of the child again. Again, non-weight-bearing infants may present with irritability, frequent crying, but no other or little other outward symptoms. They may just not move the extremity very well. So some of these things can be a little bit subtle, especially in younger children. Soft tissue swelling may be present while bruising may not be present. And here is one study. It's a little bit hard to read, but I'll talk you through it. They reviewed fracture sites, which are listed here on the left. The total number of fractures that were evaluated in this study. The middle column is that there was no bruise overlying the fracture or no bruise near the fracture. And then in the far right column, these are bruises that were near the fracture. So in looking at this data, just in general, about 50% of skull fractures do have associated bruises in this study. And then about 9% of rib fractures have associated bruises. So the vast majority of rib fractures do not have associated bruises. And also with long bone fractures, and so I'm taking upper and lower extremity fractures, only about 7 to 9% of those fractures have associated bruises near the area of the fracture. So bruises are not a good indicator of where you might have injury, especially on the body. So this is a little gal that I saw in our emergency department about 8 months ago. She is 7 weeks old on presentation. She presented to a local emergency department. Is about 2 hours out from the Twin Cities. This is not a pediatric emergency department. And her presenting complaint was that she was having trouble moving her left arm. The local physician obtained an x-ray of the arm and noted that she had a fracture through the upper part of her humerus. The fracture was stabilized. The arm was sort of kind of strapped to her chest, so she wasn't moving. And she was sent home with plans to follow up the next day. This occurred in the middle of the night. And I remember her case very well, and I pulled my notes, and the first sentence of my note said, 7-week-old, arm fracture, can't find the patient. So what happened was, Cindy got this phone call, we have this patient, we're trying to send them to you, and 2 hours have gone by, and nobody knew where the patient was. So we were all panicked. They did find the patient. The father had taken her to his parents' house, and they actually did have plans to follow up with medical care. The police took the baby, placed her in foster care, and brought her to our emergency room. So here she is. And she was very cute, very alert, appropriate 7-week-old infant. I think you can appreciate that this arm is much more swollen, even though you can't see the whole arm, but this shoulder area is much more swollen than the other side. So I get it. She had a tiny little scratch here. That's all we could see on her upper part of her body. Now, with this case, I want to show you what a patient looks like on the outside, and if you had x-ray vision, what you would see on the inside. This is what you'd see. So here's her humeral fracture. That's the one fracture we knew she had when she arrived. She also had an acute fracture through her clavicle. She had a radial fracture, a possible ulnar fracture. She had a linear skull fracture, and all of these rib fractures. She looks pretty darn good. So they're misleading. Occult injuries in infants can be missed easily. Now, we look at her the other way. It was noted in one sentence on a nursing note that she had swelling of her right thigh compared to her left. This wasn't evaluated by the local physician, and this was a displaced fracture that required pinning. and casting. And then she has all of these other fractures, including a first metatarsal fracture. I didn't even take a picture of her foot because there was nothing wrong with it. It also was fractured, yes.
Both parents have been terminated the parental rights and the kids being adopted.
Yeah, a good outcome. So what's important, I think, about this case is how subtle, if you will, the findings can be, but very subtle findings can have really significant injuries underneath. These were the only bruises we could find on her body. They don't even project well. My drawing was actually better, that she had like 3 tiny little circles here. Besides this and the swelling of the thigh and the swelling of the arm and decreased movement of the arm, those were her only outward symptoms. So, lessons learned from this case. Abusive fractures can be occult with no physical findings. Presentation of significant abusive long bone injuries can be swelling or limited movement, and that's it. And bruises need not be present. And most of the medical information that we diagnosed in this patient was obtained from the skeletal survey. And getting a little bit to about the medical history and applying it to our understanding of radiologic examinations. If you can, it's important to understand what part of the body took the force of a fall or the accident or whatever happened, whatever brought them in. Was the body moving in line with the extremity? Was there any twisting of the body in relation to the extremity? Or was the extremity retained during the fall? So was the foot caught in the couch and the baby fell? Or was somebody holding them and they fell? And you can imagine all kinds of things. But it's really helpful to understand what the witnesses or the parents or whoever brought them in understood about what happened during the injury. That helps tie the history together with the patient's development to the radiologic studies. And a little bit about development, obviously. What can the child actually do, and does that make sense with what the story is? And does the child have reflexes to protect himself during a fall or not? And Rich, I know, has shown this picture before, where the infants sort of lead with their head. That explains the 3 or 4 skull fractures we've seen of infants about 4 weeks of age who happen to be in their bouncy seat and fall off, you name it, the counter, the ottoman, the coffee table. They have no reflexes to try to protect themselves, and they hit with their head, as opposed to children who sustain more long bone fractures when they fall. So specificity of fractures for abuse. There are many fractures that have very low specificity. They could be accidental. They could be abusive in the right scenario, one way or the other. So subperiosteal newborn formation, clavicle fractures, long bone fractures, and linear skull fractures are all common with accidental trauma as well. Moderate specificity, multiple fractures. Fractures of different ages can be more and more concerning. Epiphyseal separation, vertebral body fractures, digit fractures, and complex skull fractures make those more concerning for abuse. And then fractures that have much more high specificity are these classic metaphyseal lesions or fractures, rib fractures, especially posterior, and scapular or sternal fractures. A little bit more about long bone fractures, because now I have a whole bunch of pictures to show you coming up. The most common abusive long bone fractures are in the femur and humerus. About a third of femur fractures in kids less than 4 years of age are caused by abuse, and about 50% of femur or humeral fractures in kids less than 3 years of age are caused by abuse. Some other findings that might help you consider physical abuse as being an etiology of a fracture. The number of fractures. This was a study that looked at kids up to or just under 12 months of age. The more fractures, the more likely the etiology is abusive injury as opposed to accidental. And again, as I mentioned before, various stages of healing make it more likely that it's abusive than something else like metabolic disease. And then not having any history of trauma. That's also been demonstrated to be associated with abusive fractures. So I'm going to attempt to talk about the biomechanics of fractures in children. There's not a lot out there, but again, Dr. Pierce in Chicago has one study out where she used a piglet femur model. So this is her diagram for how they did a transverse fracture through the femur. The piglet femurs were 3 to 12 months of age. This is the little mechanism that they use. It's a 3-point bending mechanism until the bone fractures. They found that the range was from 530 to 1,024 newtons, which meant I had to Google what a newton was again. 1 kilogram exerts 9.8 newtons, which is a kilogram of force, if you look at it that way. Therefore, the lowest fracture load in her study was equal to 54 kilograms of force. So, and this data correlated well with a much older study that was done, I believe, in Germany that got about the same numbers using human femurs of infants. So I think her data is correlating with a very old study that was done a while ago. So the bottom line is, at least femurs we know are not weak bones in infants. When reading about biomechanics, they use a lot of terms. They talk about force on the bone, which could be compression, tension, or shearing. These are all the stresses on the bone. They talk about load, which characterizes the application of the force to a structure, or in our discussion, the tissue in the bone. And the load creates stress, or the distribution of force within the tissue, and fractures are a result of this stress causing failure of the bone. So that's how people talk about it in these terms. There's this term fracture morphology, and I can read a little bit about what a few people write about this. In the clinical setting, it's the type, the direction, and magnitude of force that can be applied, inferred from radiologic appearance of the resultant fracture. So they're reading the radiologic studies and inferring something about the force and the magnitude and the direction that happened to cause that injury. Other people, Dr. Pierce again, the bone fracture morphology reflects the direction, force, and ability of the tissue to resist that force. And the overall type of fracture reflects the type of load or energy which was needed, which needs to be related to the history. So again, it's sort of trying to understand the mechanics of the injury and tying the radiologic studies together, again, with your history and what you know about your patient. So from one of her review papers, I've taken some photographs where she tries to describe the type of force that causes fairly common fractures that we see. So a buccal or torus fracture occurs typically in the distal 1/3 of the metaphysis region. And it fractures there because the bone is more immature. That's where the bone is growing. It's a little bit more immature and a little bit weaker. And so this is the direction of force to cause that fracture. Spiral fractures are very common in infants. It's produced by a torsional load or torsional force around the bone, and it is not diagnostic of abuse. And here's a transverse fracture. The fracture line is perpendicular to the axis of the bone, and some people feel that it might actually be more common in abuse than spiral fractures are. And here's an oblique fracture. This has, they think, a load or a force that comes down the axis of the bone plus a twisting mechanism to get this type of fracture. And classic metaphyseal fractures are here. These bucket handle fractures. Bone failure is due to shearing stress that occurs through immature metaphyseal bone. So I'm going to try to go through several cases that I've seen with the story associated with them. So here's a fracture. This is a 2-year-old who was being carried on his cousin's back, a teenager cousin. The cousin tried to spin the child around and grab him on her front when the child let go and spun and landed on his leg and had difficulty walking immediately and presented to medical care. So it makes sense with a spiral fracture, a good age for it, and actually a fairly good story for that. Here's another long bone fracture. This is a 6-month-old. He was about the 95th plus percentile. He was a large chunk of a kid. He was placed in the middle of a king bed that was elevated for some reason off of the floor, and he backed off of the bed because he couldn't crawl forward. He only could scooch backwards. They found him on the floor on his hands and knees. It was a hardwood floor in a lot of pain, witnessed by, not witnessed, but heard by several people. And this is his fracture. So a fall might make sense. We actually obtained a skeletal survey on this kid to make ourselves feel better. Here's another femur fracture. This is a 7-month-old who fell from a dresser. Parents were both at least a foot taller than I was, so they were using their dresser as a changing table and fell from almost 4 feet. She was on a changing pad. It started to slip. Dad tried to grab her, couldn't, and she hit the floor. And here's another one. This was kind of a goofy one. It's not a long bone fracture. It's a foot fracture. This is a 2.5-year-old who liked to jump a lot, would jump from their bunk beds with his brother, would climb up on countertops. The mother was just distraught that she couldn't keep this kid safe. He was standing up on a bar stool and jumped up and planned to land on his butt, but didn't clear this foot and came down on it. Had immediate pain. Mom put him down for a nap. When he woke up, the grandma said, his foot's swollen, we have to take him in. And so here's his fracture here. So it's important, I think, none of us were there to observe these things, but it's important to try to put the history together with what we're seeing. Rib fractures, I'm going to try to move a little bit faster. They're common in abusive injuries. There's a pretty good positive predictive value for abuse in kids less than 3. The differential is pretty obvious. Kids have had operations, they have abnormal bones, or they've had a major car accident. The literature on CPR and rib fractures is that they're very rare. And if they are there, they tend to be in an anterior location. Rich has shown this picture before, the mechanism, they think. This impressed me when you really look at this again. If this is the normal position of a rib, and to get rib fractures, you're saying that the rib has to be displaced this far back, and the spinal transverse process is used as a fulcrum, and you get fractures back here. But it just sort of, it's a drawing. I don't know how well they know this in real life, but it would have to be displaced pretty significantly to cause fractures there. And this again is one of Rich's pictures, but it emphasizes why skeletal surveys are obtained 2 weeks apart. So this is on presentation. The clavicle fracture is easy to see. When this is blown up, it's actually fairly easy to see. I'm sure it's hard to see where you're seeing. What's not hard to see are all of the other rib fractures that are now have callus as they're trying to heal 2 weeks later. So that's the importance of getting skeletal surveys 2 weeks later in follow-up, because it's easy to miss them on presentation. They're hard to see if they're acute. CT scans can be used to find, here's callus formation, here's a fracture here. And with reconstruction, you can see callus formation here and here. So that makes it very clear if your child or your patient needs to get a CT scan. Bone scans are used much less frequently, as you can see, because if there's fractures anywhere in here, you'll miss them. It's just all black. But I still have seen them. We've seen them once recently with a referred case where they had a chest X-ray which showed 1 or 2 rib fractures, but then the bone survey actually picked up more. All right. Here's a case presentation. So this is a 6-month-old female who presented to our emergency department with crying and fever. That's her presenting symptom. 3 to 4 days earlier, she was noted to be crying more than her usual. The day prior to exam, she vomited a few times, but was taking her normal bottles. Urine and stooling patterns were normal. On the day of admission, Dad said she cried all day. She didn't vomit at all. She has a history of reflux. And he says she just seems to want to be left alone, but settles easily, calms down easily. She ate a regular amount of bottles. She had normal stool and wet diapers, no URI symptoms. She lives with her parents. She's not in daycare. She has no sick contacts. And here's her physical exam summarized. Basically, she's tachycardic and she is febrile. She's tachypnic. She's a normal-looking child. This is all normal. She's moving all of her extremities. Whoops, I'm running out of my battery. And she has no skin findings. So the working diagnosis is that she has a urinary tract infection. So they go to obtain a cath urine, and she's treated with ibuprofen. I don't know this for sure, but I would imagine when they were obtaining the cath urine, somebody noticed that the left thigh looked more swollen than the right. And here's her x-ray. So she has a mildly displaced oblique fracture of the distal left femur. We also obtained a skeletal survey in the emergency department. She has 4 left rib fractures, an acute clavicle fracture. You can't see it very well because I chose the oblique view, but she also has a right clavicle fracture which has callus on it. She also has left distal tibia and fibula fractures, and you can see the left femur fracture still in this picture. So the mechanism of injury. She didn't present with a history of injury. Now going back and talking to the family, there is a history 5 days earlier. She was in a baby swing that had like a plastic lap thing that latched down across her, and she was pulled out of this because she had spit up, and the family noted that this would have come right across where the fracture was, and could that have been the explanation? And all of the other fractures didn't have any explanation. So we felt, yes, I mean, it does make sense. It couldn't have been a gentle removing the baby from the swing, but it actually does make sense for how that fracture could have happened. So the indicators of abuse in this case, the long bone fracture of a non-mobile infant is concerning. The number of fractures with different ages are all very concerning, and only a partial history to explain one of these. So we looked, the baby has normal vitamin D and calcium levels, alkaline phosphatase levels. It was interesting, and I can't remember, I apologize if you're in the room, one of the residents and I, we looked at this kid really hard, and we thought, her sclera kind of looked gray, not really, I don't know, let's talk to endocrinology, and they agreed, and so we obtained a genetic screen for OI. That's negative. It takes 4 weeks to come back. Obviously, the child was placed in foster care, so she's been in foster care now for about 7 weeks, and the case is still under investigation. So now here's more of the story. She has a twin. Now what do you think? What do you do with a twin? Says the radiologist. Are you even concerned? I hope so. A little bit. She's fine.
Unless the twin is the one hurting her sister.
It's true.
Keep her twin.
She's bigger. She's growing better. She has no reflux. She might be fine. So anyway, so what we did, I talked to the emergency room physician. They were kind enough to keep the mom and the twin in the emergency department. He did a full physical exam on her and documented it. She is normal. She's a normal, healthy 6-month-old baby. We admitted, oddly, the other patient to the PICU, not that they needed it, but because the floors were full and I happened to be on call, so it just worked out fine. So, what's the prevalence of abusive injuries in siblings? I actually heard this talk at PAS last year. So this group hypothesized that household contacts of abused children were at higher risk for being abused themselves. Makes sense if you're in an abusive environment. They found that almost 12% of contacts less than 5 years of age had one abusive injury. Twins were also at an increased risk compared to non-twins. None of these siblings with fractures had associated physical exam findings. None of them. Okay, now the rest of the story. So, the 6-month-old, I told you, had a normal exam by a pediatric emergency room physician looking for injuries. found nothing. Her skeletal survey demonstrated bilateral healing clavicle fractures, an acute distal metaphyseal fracture. She had other long bone fractures. She also had a fifth metatarsal fracture, so that's hard to do. I can tell you, just for interest's sake, we actually did head CTs on both of these kids. It's kind of hard to know. It likely overkill. Neither of them had neurologic changes, but in talking over these injuries with Glenn Seidel, he was really impressed. He said whoever did this was really angry. I mean, both of these kids. So we actually did. It's probably overkill. Both were fine, thankfully. So hopefully I've covered why abusive injuries can be hard to diagnose, especially in kids that are not mobile yet, even when you're looking for them. And understanding the mechanisms, or at least what people who do this type of work understand about the mechanisms of bone injuries, and the importance of using the radiologic data in conjunction with the patient history so that it helps formulate an inclusive differential diagnosis. And then we've reviewed the data to date that supports abusive injuries are a common cause of nonspecific symptoms which commonly are seen in primary care clinics and emergency departments, and therefore this diagnosis needs to be included in the patient's differential diagnosis. So how do we make ourselves better? These are the guidelines that were actually used in the sibling study. They kind of went through a very detailed diagram, but in summary, they said that all kids less than 2 years of age should be considered for a skeletal survey if you don't know what's going on. They did obtain a skeletal survey for all kids that were 6 months of age or less and some type of neuroimaging, either head CT or MRI. And then they repeated the skeletal survey for all kids less than or equal to 6 months of age 2 weeks after the initial one. So that's what they did in the sibling study. And ours is very similar, or at least our recommendations, is that any child who has significant injury where there's not a clear mechanism or witnessed should be, we should obtain a consult for the child abuse team. And then in all children, so that's all ages, all children less than 2 years of age with significant trauma should receive a consultation as well. And it's based on all of this data that's coming out because we don't want to miss anybody. And because I have a few minutes and then we'll have questions, anybody has questions, just to talk a little bit about child abuse pediatrics. It's the newest subboard that's available. It's typically a 3-year training program with clinical and research components, just like every other fellowship in pediatrics. The first board exam was given in 2009. What's interesting, and I heard this talk actually also at a PAS meeting 2 years ago, is that the first board exam that was given had 200 some, I think, anyway, a fair number of people took it. A lot of these people were grandfathered in. There are people like Rich, like other people that we work with, who have done this their whole life, who have never done an official training program because they didn't exist, and they were grandfathered in, and they took the board exam. And then, and then in 2012, all training for child abuse pediatrics has to take place in an accredited fellowship program. I think I have more. Oh, yeah, this is where I talk about this. It's a really underrepresented yet desperately needed pediatric field. So currently there are 264 board-certified child abuse pediatricians. On average, during 1 year, there's 22 fellows in a program any of the years, year 1 through 3, in training. And about 27% of the child abuse pediatricians right now that are board certified are over 56 years of age or older. So the concern, I didn't mention your name, but the concern is that there may be a lag in time as people who have been doing this for their whole careers before it was actually a real subboard are going to retire later. before more people move into the field. And the physician-to-child ratio is there. It's 1 to 313 some thousand. And in 2011, there were actually 7 states without board-certified child abuse pediatricians. Not that they don't have child abuse and protection teams there, but they don't have anybody that's board-certified, because this was from the American Board of Pediatrics website. So there's a plug for people who are interested in doing this. So summary points. Physical abuse of children is a significant problem. I think I've convinced you of that. Very limited number of experts in the field, and therefore we all need to educate each other to take better care of the children. And then one more quote from Dr. Pierce: few misdiagnoses in pediatrics have such associated lethality if we miss these kids. And then I need to thank Uncle Richie. And Mark Hudson is in the back. Thank you for coming. Carolyn Levitt is also at St. Paul. And the team here and MCRC in St. Paul. And then my family for allowing me to have a midlife crisis and do something different. So there you go. I'll answer questions.
I gave orthopedic grand rounds at the finish of the whole thing. The senior professor of orthopedics said, "Yeah, but if it's a good family, we don't have to report it, do we?" And that scared the hell out of me. So I said, I can't look at anybody and think they're not capable of anything. That's why we have community partners. So I just said that to him. All the other people got it, but he's just kind of scared of it.
So, I've been told that we should only be doing these skeletal surveys during the day when there are certain radiology techs available. Is that true?
Yeah. If there's a kid that you're wanting to send home, that's a special circumstance. We like to check staff before they take leave. And they take an incredible amount of time for a tech to do, because it's a very large number of sequences. So at night when they're overwhelmed. Oh, I'm sorry.
Here.
So at night when there are, multiple things going on in the hospital and probably 2 techs to cover both Riverside and Amplatz. I'm not sure exactly how many techs at a time, but they're very stressed. And then to do that many sequences, it's just a very long exam that if it's an inpatient, there's really no reason not to do it during the day. We can check them very easily. The techs are less hurried because, they're better supported, and we just tend to get better images under those circumstances. And sometimes our pediatric techs are at night, too. I'm not drawing a line between our few pediatric techs and others, although someone in the corner over there might. It's just a hard exam for the techs to do in the middle of the night because it just requires so much resources.
So where does that leave you?
Well, usually if we have concerns, we wind up admitting them to the trauma service. And the trauma service has developed a fairly clear routine of involving Rich and company evaluating these patients.
And I think from a trauma perspective, that's fine. They're sort of readily available to accept the kid. I do believe all child abuse cases should be in a trauma service anyway, so that's not an issue. And if the issue is the quality or efficiency of the night crew, then the minimum overnight is valid. Carrie, a quick question. On some of these kids who come in with abuse, like the one we just saw, your first kid, I think I helped take care of that little infant, is the kid was neurologically stable. And I'm wondering, would an MRI, from radiation standpoint, be just as valid? Because the kid end up that 7 week old end up with a CT scan. I'm wondering, can you develop a policy that kids are clinically stable, looking around? Can we just do, inpatient, maybe kid inpatient, and just do a sedated MRI?
Or sedation.
Right, and that's the that's just obviously it's balancing between the two, but all require radiation.
So I think, I'm not sure, but I think the gold standard is head CT, although in this one study that I referenced, they said neuroimaging, CT, or MRI. They need sedation. It's another story, but our sedation unit doesn't do children under 6 months of age. So they're getting to be more difficult to do. If they're the quick 5-minute MRI that neurosurgery is doing more and more, and that is okay to rule out,
No, that
No,
won't be
no,
any good because you
no.
can barely see ventricles on
Yeah.
that sometimes, so.
Yeah.
That is just for following ventricular sizes.
so
not
then
for-
it's a 45-minute sedated MRI is what people need.
If they're under 6 months, they won't do it.
They won't do. Yeah, we didn't say that, but
We sneak around.
What about ultrasound in the younger?
You are pretty limited looking at this part of the brain out here. You know, no matter how hard you try, the fontanelle limits
So it's
your
rolling,
ability
but
to
then
move
there's
the
a
needle.
roll.
Yeah, and the older they get, the smaller the fontanelle is, the harder it is to see that portion. I mean, it's great for intracranial disease in the center of the head, which is what you see from the NICU all the time. You can see large subdural collections, but real small things, subtle subarachnoid hemorrhage, you're not going to get it.
So did you do, I mean, we routinely have been doing liver function tests and a urine, looking for occult abdominal injuries too, and the studies show that about 10% will have those in this abusive setting. I mean, I know you're talking about fractures, but I just wanted to highlight that as a part of their screen as well.
right, yeah, we typically obtain baseline organ function labs and yeah, do the normal sort of trauma workup.
Do you guys, as a standard, usually get ophthalmology to do a formal eye exam on the infants?
I think if they have abnormal neurologic exam and or an abnormal neuroimaging study, then we will. And then if there's still questions, we will. But if the kid is fine and the head study is fine, I don't think we have been. And I don't know if Mark or Rich, if you would say anything different.
Yeah, I mean, I think the data on having a positive eye without anything seen radiographically is slim. One paper that has a few kids, but it was called nationally, and all ended up with another neurologic symptom. So, as a screen, the eye exam is not great, right? Doesn't have a lot. There are some places that do it for every kid. They do basically all the imaging and all of the eyes.
Okay.
Very try it, whoever does it.
Is it standard to get a vitamin D level and calcium, like right when you know that there's no fracture, you're suspecting that, or do you guys kind of wait until later?
It seems like, and I don't, it seems, no. I don't know that it's standard, but it seems that you can get yourself in trouble because if a child presents with fractures with no radiologic evidence of metabolic bone disease, you wouldn't normally do that on a child you weren't worried about with abuse. But then once you go down this abuse pathway, there seems to be some difficulty if you don't get it. It just gets to be a slippery slope because if you do get it and it's normal, that's great. And if you do get it and it's abnormal, it may mean nothing if they have no metabolic bone disease on the x-rays. And it just seems to be a slippery slope when it goes to court, only because I saw Mark struggle through that about 6 months ago. So it's hard. I think as medical providers, you do the right medical thing, and you try to do no more than that. And I worry a little we may have gone overboard with this twins case because it prolonged the evaluation of them by, I think, law enforcement for so long because we were waiting for this genetic test to come back. So I think you do the right thing as best you can, but you do worry about, are you making things more difficult? That's all I know. Yeah.
Is there any data out there to see how many kids that were not due to abuse or reported to the abuse team? I mean, any sensitivity, specificity about ER docs? How good are they in their suspicion?
I don't know if there's data, but I think it's important. I was asked recently, how many cases do you see that you feel are abuse or are going down that path and how many aren't? Our numbers here are 50-50 since I've been doing this for a year.
Is that a good goal for us as pediatricians to get you?
I don't know, probably.
50-50 call to you is a good
Yeah,
goal?
I don't
We're
know.
obliged by law to do that.
No, I know.
I mean, it's
But
not something
again-
that's sort of optional. If I think that it's possible, I'm obliged by law to report it.
True, but
So are
how-
you.
No, I know. And I do that. But the question is, what is your threshold to be worried?
Oh,
I mean,
and
are
this-
you just calling because at any time?
Yeah, and this isn't just like our reporting, but this is of the cases that we get that we're evaluating, kids with fractures, like I showed you a whole bunch of them. So it is about 50-50, at least the ones that I've seen over the past year. I don't know if, maybe people do have data on that, but I think they worry when 90+% of your cases get reported because you think they're all abusive. Well, that's a little concerning then too, because then you're not probably working these kids up appropriately as far as your differential diagnosis.
Carrie, in kids who have chronic illness, I mean, the incidence, as I recall, is higher of abuse in those kids. But what we see a lot of is not necessarily physical abuse, but the medical neglect. And I don't know if, aside from sending the kid home and letting them fail therapy, to catch that before. I mean, you know, we call pharmacies and do all that stuff, but the family has to fail before action can be taken.
And yeah, I don't know if we necessarily want them to fail. And what I don't have a great sense of is what all can CPS provide, because you'd like to have them be involved in instances like that in a positive way, where they're providing services to support the family to keep the child in the home and provide the right medical care as in neglect cases or difficult, complex medical cases. But I don't know the numbers on that, how frequently that happens, but you'd like to think that there's a mechanism that we can place nursing in the home, we can provide other services to the family so that they don't fail.